morning, everyone. It's so good to see you all. We're going to introduce my friends, Jeff and Kim, who have been instrumental in doing many good things over the years, not the least of which, Kim Garcia, as the Nevada Department of Health and Human Services Gambling Program Coordinator, has helped make sure for the last, how many years, Kim?
4.
The last 4 years, she makes sure that those of us who have the gambling grant get paid and get audited. Very important things in our life. And Jeff, who has been a graduate of the UNR Business School program, or economics, right? You got your Ph.D. in, was it economics?
Clinical psychology.
Forgive me, I'm associating you with Dr. Eatington. So he gets his Ph.D. in clinical psych from University of Nevada, Reno, studies gambling, goes on to run the Oregon program of gambling, everything that has to do with gambling in Oregon, and now is our consultant. I'm generalizing. You can give more specifics if you want, Jeff. I just think he's a guru. Now he consults with all of us in Nevada who want to continue to do good work in Nevada relating to gambling and helping gambling families. And because of his international access, he gets to guide all of us in best practices and keeps us on our toes. So I just want you guys to know that you're in good hands here with this talk. What you're going to hear about, don't you think it makes sense that people in the world of substance use should know more about gambling? Raise your hands, nod your head, wave. Yes. So there is a way for this to happen, and they're going to tell you how we're doing it in Nevada. Give a big round of applause and make them feel welcome, Kim and Jeff.
Good morning, everyone. I'm happy to be here today and hope that you are all enjoying the conference. If the people that do not know me, I'm Kim Garcia, and I'm with the Department of Behavioral Health with Wellness and Prevention. I've been doing the Problem Gambling program for 4 years. And I would like to know in the room today, with a show of hands, who provides treatment services? Okay. Who provides treatment services? Who provides prevention services? Okay. Who is from the gaming industry? Okay. Who is a student? A student. Here, I'll adjust this. Is that better? Okay. Who receives Problem Gambling Service funds from the state of Nevada? Select few. Okay. So today, I'll move my paper over here. So today I would like to share how the state of Nevada collaborates with its partners to address this issue and provide services to residents of Nevada. I'm just going to go over some basics. Our mission is to support effective problem gambling prevention, education, treatment, research programs throughout Nevada. Our vision is to improve the health of Nevadans through a sustainable and comprehensive system and programs with services that reduce the impact of problem gambling. Our primary target is for Nevada adults and adolescents at risk and have gambling issues. To support, our top priority is to support a comprehensive problem gambling treatment service system. How are we funded? We are funded through the revolving account of the prevention and treatment of problem gambling, as we refer to as the Problem Gambling Service Fund. This was created by Senate Bill 357 in the 2005 legislation, codified in NRS 958A. During the 2021 legislative session, this fund was appropriated approximately $2 million annually with state general funds for state fiscal year 2022-2023. We use these funds to fund problem gambling services, support services, and for prevention and treatment. We are special to have an advisory committee. What is our advisory committee? The advisory committee was created by DHHS to inform and advise the department and other state agencies on problem gambling in accordance to the NRS 958A.60. The ACPG meets approximately quarterly and makes frequently forms work groups to address problems and policies and program issues. We currently have 9 members on our committee, and at this time I would like to acknowledge our ACPG members. If you would please stand when I call your name. Our chair is Alan Feldman. Our vice chair is Denise Cork. Connie Jones. Caroline Leagan. Carol O'Hare. Ted Hartwell. Dr. Shane Krause. And we have 2 members that were appointed on Monday that are not here today. We have Leslie Pittman and Richard Taylor. All these individuals are appointed by the governor, and they serve a 2-year term, but many of these individuals have served on the ACPG for multiple terms. We are fortunate to have such a dedicated and esteemed group of professionals volunteering their time to serve on the ACPG. I just want to say thank you for your public service. Nevada Problem Gambling Services is guided by the DHHS Problem Gambling Service Fiscal Year 2022 Strategic Plan and the 2022 Provider Manual that we regularly update as problems and services arise. Let's talk a little bit about our problem gambling system components. It is a very robust system. This program system represents 6 core program areas: prevention and public awareness, research, workforce development, treatment, information management, and administration, as you see on this chart. But I'd like to look at each of these components individually and briefly discuss what they do and the amount of money they receive. Prevention. They receive approximately $300,000. This includes our public awareness campaign, Project Worth with KPS3, and outreach efforts provided by the Nevada Council on Problem Gambling. Research receives about $200,000. This includes the mini grants that you heard from yesterday and we'll hear from later today, and the BRFS gambling module. The workforce development receives about $70,000. This includes providing services and support to the Nevada Council on Problem Gambling for this conference, and collaboration with UNR-CASAT for workforce training opportunities, and working with the Board of Examiners Licensing Board for drug, alcohol, and problem gambling counselors. Treatment. Treatment receives approximately $1.1 million to provide free to low-cost treatment for Nevada gamblers and their concerned others. We currently fund 4 treatment centers. Bristlecone Problem Gambling Center in Reno. They provide residential and outpatient services. Mental health counseling and consulting is in Henderson, Nevada. They provide outpatient services. New Frontier Center in Fallon. They provide residential and outpatient services. Dr. Hunter International Problem Gambling Center in Las Vegas provides outpatient services. We also have the Gambling Treatment Diversion Court. This includes a court coordinator and monitoring services for persons enrolled in diversion court. Our information management gets approximately $200,000. UNLV provides our evaluations and utilization reports for all of our treatment providers. UNLV produces an annual gambling treatment services evaluation report and provides quarterly progress reports for detailed with their grants on their performances. And administration, it's approximately $130,000. This includes state of Nevada staff and our Problem Gambling Solutions Technical Assistance Contract with Dr. Marotta. As you can see, the entire system is impacted by the performance of each of these components. We know that treatment works. We are always trying to increase our number of people we serve, and Dr. Marotta is going to discuss our newest integration project. Thank you.
Good job. Okay, I'm going to let you all in a little secret. That was the first time Kim ever talked to a large group. So how about that? Really? I mean, can you imagine how terrifying it must be to get up here and just talk with a bunch of people like this? Carol?
Yes, and we're going to be sure that you do that exact thing in front of the legislature, because that was amazing.
Yeah. So congratulations, Kim, on your first public presentation. And thank you guys for being here. It is so important that you're here. I always feel a tremendous amount of gratitude whenever I speak to a room full of people who are at a gambling conference, because you guys, you're the people who care about this issue. You're on the front line. If you're not doing treatment, by virtue of you being here, you're ambassadors to promote this message. You guys are my heroes. So thank you so much for being here. Okay, so why do we need a new initiative? Kim just kind of described the system. Nevada's very fortunate to have the system it does. And as Kim mentioned, there's always room for improvement. Now, where are we going to put our efforts? We have so much time, we have so much money, and I'm going to describe to you kind of why we are taking the path we are in terms of developing services in Nevada to reach more people in need. And to really address this question, I think we need to step back. I'm going to turn this off so I don't get feedback. I don't know how. One of the things that we, problem gambling or addictions, or engaging in things of excess has been something that's been recognized for a very long time. And it's been an area that has been of concern, but we could argue not enough concern. But over the years, we have learned a lot. We've learned a lot about problem gambling and about the continuum of gambling behavior. Now, it wasn't that long ago, certainly when I first entered this field about 25, 30 years ago now, is we viewed gambling disorder, it was called pathological gambling back then, as a continuous progressive disorder, right? Kind of like diabetes. It's something that once you have it, it's going to be with you, it's going to progress. And back then, what did we say happens with an individual who has a pathological gambling disorder? What are their ways out? Death, prison, insanity, or recovery, right? So that's the way we saw things in not really that long ago. It was this kind of progressive disease, which certainly had a lot of implications in the way that we dealt with this issue. Whoops. And now what we know from some of the more recent longitudinal studies, so these are the studies that follow groups of individuals over time, sometimes for over a decade. We find that what happens when we follow these cohorts across time is there's a lot of movement. Now, what do I mean by that? So in time one, we might find that the majority of people are out there, they're either not gambling or they're gambling at recreational levels. But there are some that are in this risk category or some that have some problems, and a smaller group that has a severe gambling issue, probably a clinical issue that could be diagnosable. We go back and the researchers go back and they asked a similar set of questions. They did it time 1 at 3 years later, and they find that some of these individuals who are at risk didn't get worse. They actually kind of are out of a risk category. Some of the individuals that were at risk progressed, right? And then some of those at the more severe range went down, sometimes all the way down into a no risk category. So 3 years later after that, they come back and they ask the same questions again. What do they find? So those individuals who are now at that severe gambling category, those that are clinically can be diagnosed as having a gambling disorder, where are these individuals kind of coming from? Well, a number of them are just, they haven't moved. They've been in that category. Some of them are coming from, they've progressed. But one thing we know is those individuals who weren't gambling at a problem level are more likely to stay at that non-problem level. Those individuals who are not at that problem gambling range, that they're more likely to have been there if they ever had, on time 1, if they were reporting a gambling problem and then they went back down. So basically, the main takeaway is people move around. There's a lot of fluidity when people engage in their gambling. To problem levels, they might bounce back down. But the other big thing we know about this, one takeaway is people move around in this severity. The other one is those who have had a problem in the past are going to be at higher risk for having a problem in the future. Makes sense, right? So this also means, like, if we want to help those individuals who are in need, we need to kind of move fast, because they could come out of that. They could, for all kinds of reasons, they might move to a lower level of gambling where they might be less motivated to kind of get treatment. Now, we want people who need help to get the help, because if they do, they're less likely to, again, bump up. They're less likely to move into kind of problem levels. And in Nevada, we know, and you've heard about this from other presenters, that in Nevada, we have a higher percent of individuals who have gambling problems than in other places in the country. So it's quite high. So Ted talked about this in his last talk. These are the numbers that when the adjustments have been made, but really as high as 4 out of every 100 people, or another way to look at it is 1 out of every 25. That's staggering, right? That's a lot of individuals. It's more common than these other things that get a lot more attention, including being a redhead. Unless you're in Ireland, then maybe it's higher. So we're dealing with a disorder that's really pretty common. However, few people are presenting for treatment. Kim talked to you about some of our treatment data. So we have this, one of the things in Nevada we have is this really wonderful treatment system. Specialty providers, they do magnificent things with their clients. They save lives. They save lives. That's what they do. Okay. However, we're not seeing very many people in our system. Nevada has this great resource, but people aren't kind of coming in the numbers we would expect them to come in at. So we're talking, I don't know, around 500 people on a good year kind of thing are coming in, out of the thousands of folks that need help. What's going on? How come, where are these folks? Why aren't they showing up? Any ideas? What? They don't know where to go.
Sometimes for the Hispanic population, when they come to our agency, we don't have, we're for profit. If we don't do it pro bono, we don't know how help.
Ah, great. So some of these folks that they might even show up for help. However, the help they don't have the support because there's only 4 state-funded treatment centers, okay? And then often there's difficulty accessing insurance if they happen to have insurance to treat this. And so it has to be done on this pro bono basis if it's done at all. So that's another reason. But people aren't showing up. So this is an issue. We have these great resources. We have a terrific need here in Nevada. but people aren't there. Now, one of the reasons why people aren't showing up in larger numbers, and I think, Cheryl, I think I heard you say denial. Did you say that? Okay. Is they have to, one of the prerequisites for coming into treatment in the gambling treatment world, which, by the way, is a little different than the alcohol and drug treatment world, is they have to recognize they have a problem. Because where are these people coming from, right? They have to recognize they have a problem. If they don't recognize the problem, nobody's sending them, well, Cheryl does every once in a while, but nobody's sending them, or Judge Moss, nobody's sending them to treatment. I shouldn't say nobody, it doesn't happen much. When you compare it to the drug and alcohol treatment field, they're seeing the majority of clients entering public services are there because they are directed so, they are encouraged by the system in one way or another. If they want to maintain their privilege, or I don't know if it's when we call it privilege, if they want to maintain custody over their children, they might have to enter drug and alcohol treatment. If they get a DUI, they're going to be required to go to a DUI class. So there's all kinds of ways that they are being kind of moved into the system. Now with problem gamblers, that's not the case. So this is an issue because they have to recognize they have a problem. And when it comes to gambling problems, so many of them don't. So this is my dad. So my father was a problem gambler. So this is our story. Grew up in San Mateo, California, and Bay Meadows, which is a racetrack, was we were on a little bit of a hill, and when the horses were running at night, it would actually light up part of our house. I mean, we were pretty close to it. So we had this kind of constant reminder the track was there. He was somebody he was a truck driver all his life. This is back when you got a job, you stayed in that job until you retired. You know, that's like wild, huh? But that's what used to happen. So he had one job, he was this truck driver. His company, which was Railway Express, went out of business. And so when he went out of business, they also, remember this, when people had really good pensions, right? And so he was able to retire when he was 55 because his company went out of business and he had this great kind of pension plan. And you're 55, you know, he got bored, right? He got bored, and so he started going to the track more to keep himself entertained, and one could see, you know, it developed into a gambling problem that was pretty severe. So now with him, he never thought he had a gambling problem. What was his problem? He had a money problem. He also had the problem with he didn't have a supportive wife. You know, so my mother was always like, stop feeding the horses. I'm tired, you know, and this is another thing, is probably a more historical thing, but he was on an allowance. I mean, thankfully, she did all the financial control. So he was always asking for a bigger allowance. So that would kind of cause families problems and, you know, arguments. And so in his case, he never saw himself as having a gambling problem at all. Now, for him, he was at the VA, he loved the VA. He was a vet. He loved going to the VA, and he loved, like, if he had any kind of problem, he wanted to be put in the ward with all the other vets. You know, he got mad when he got put in a private room. You know, he wanted to be, and he was somebody who was also, interestingly enough, kind of being seen in different mental health clinics as well. So he had some anxiety issues, and some low-level depression, some dysthymia. And so he was being in mental health clinics, he was being in kind of various aspects of the VA system. And nobody was talking to him about his gambling. He didn't see it as a problem, so he wasn't certainly bringing it up. He didn't want to bring it up. But he is somebody who was a problem gambler, was causing all kinds of issues, didn't get talked about. What do we need to do in order to get these people who don't see they have a problem? We need to bring this into our culture of caring. So those of you who are kind of working, well, I'm kind of, you know, preaching to the choir here, but one of the things we need to do systemically is get our culture of caring system, which means our medical system, our behavioral health system, to be talking about gambling with their clients, because the clients aren't going to bring it up on their own frequently, okay? And this is just another kind of little aside just to drive this point home. Just I think it was last month, one of the things I do is I do these expert witness stuff, and I work for, or defense attorneys will kind of hire me to do evaluations for clients who have gambling issues. And so I met with this person who was in federal court for felony theft. She was taking money out of the ATM, which she was the store manager from, and she was going to the casino and gambling. So by the time I see her, which is now, the court system kind of runs a little slow, especially during a pandemic. So it's been like a good year since this is she got busted by an accounting issue. The accountant came in, they saw that, hey, we got some missing money. So I do the evaluation with her. One of the things I do is, I go through these different checklists of symptoms, and one of the questions on the Canadian Problem Gambling Index is, did you ever believe you had a gambling problem? And you could answer, I think a 1 to 3 kind of thing. This is somebody, okay, who's being prosecuted for stealing money, embezzling, who through all the other investigative reports, was documented as the friends were saying, yeah, she has a gambling problem. Everybody thinks who said, no, I don't have a gambling problem. She's going to be going to court soon for this embezzlement charge, and she still does not see she has a gambling problem. What was her problem? Her problem was, she did have problems. She was in an abusive relationship, and she did have like PTSD. And this is a little side note here. So this is somebody who had PTSD and a gambling disorder. What do you think I recommended in my recommendation to the court? I recommend, of course, like they talk about her gambling. But one of the things that the research is kind of starting to show is for those individuals who have PTSD and a concurrent gambling problem, you actually want to address the PTSD first. That should be the primary issue. So it's not that somebody who always has a gambling problem, that's the focus of the attention, but it always needs to be part of the approach that's taken. Okay, so this is some kind of older data, and the reason I don't get too hung up on these numbers, but this is to demonstrate that there's a lot of comorbidity with individuals who have gambling problems. So comorbidity means they might have, or they have a history of a psychiatric disorder. It may not be at the same time they had the gambling disorder, but somewhere in their history, they've had these struggles, all right? And so we know that people who have struggles with other mental health issues are at much higher risk of also developing a gambling disorder. And we know that frequently there's a lot of other issues, like my father, okay? He had an anxiety disorder, he had a depressive disorder, and he had a gambling disorder. So he was one of these kind of 3. Now, did he have them all at the same time? I don't know if he did. I'm not sure if he did. So it doesn't necessarily mean they're happening all at the same time. But the reason this data is important, the reason I'm showing it to you, is these folks who are having these other behavioral health issues are showing up for help frequently. Sometimes it's through their general practitioner where they're getting antidepressant medication or anxiety meds, but they're being seen within our healthcare system. So these folks are out there, they're being seen. Are they being asked about their gambling? Well, we do know from studies that look at the general population, and frequently when these studies are being done, they're done in different settings. Sometimes they look at the general population, sometimes they look at clinical settings. This one, in the general population, we know, and this isn't the only study, but from studies that folks with a gambling or with a substance use disorder are about 3 to 5 times higher odds of developing a gambling problem or being a problem gambler. And then when we look at gambling disorders in the substance use disorder treatment settings, we find that these rates are also quite high. Remember, within the general population in Nevada, we're talking, I don't know, depending on how you interpret this old study, somewhere between, like 2 to 4%. Could be like, I think Ted was saying as high as 6%. So here we're seeing it's much higher when we go into a clinical setting. Now this is not Nevada data. I would expect Nevada data to even be higher. So is gambling disorder being addressed in a substance use disorder treatment? So the answer is sometimes, right? So this is a study that I did in Portland. It is a multi-site study. We went into 13 different residential substance use disorder treatment centers. All right, we went in there, and this was done everybody for 6 months who entered these treatment centers. They kind of came into one of our groups that we provided on gambling, but before we did the group, we would kind of give them this survey, all right, with all these different, which included, I think the SOGs, it might have been, this was a while ago, along with a whole bunch of other questions. And what we found was 20% scored in the probable pathological range. Now, the reason we use the SOGs in this study, and the reason I want to encourage you to use something like that, is it looks at historical. So it doesn't mean that they had a current problem. It's not that 20% of them had a current gambling issue, but 20% at some point in their life had some kind of gambling issue, and many of them would have risen to the level of something that was a diagnosable issue. So the reason why I promote that is because that other data I showed you, where we know from the longitudinal stuff people bounce around, but they're much more likely to move into this severe gambling category if they've ever been there. All right? So we know that those people who are more likely to have a gambling problem had a history of a gambling problem. So we're seeing that 20%. Now we asked, is it in your treatment plan? Is it, or is it in your relapse prevention plan if you've done that yet in their treatment setting? And only 14% of the 20% that scored. Now this is a pretty large sample, right? So only 14% said, yeah, that actually is being addressed in my current treatment plan. Not great. That should be 100%, right? Okay, and then nearly a third said, I have concerns that gambling is going to get in the way of my recovery. So even though a third of them said it might get in the way of my recovery, I'm concerned about that, it's not in their treatment plan, which is another problem because this is supposed to be a collaborative process, right? I mean, in developing the treatment plan. So what we're finding is it was not happening across these 13 agencies, and this is in Portland, it wasn't Nevada. And then we also, by the way, asked about family members because this is something that doesn't get asked enough. And 15% of the clients said they had a problem gambler in their household. So a number of these people who were in there for substance use treatment had a problem gambling in their household, and then 20% of that group said that they believed having that problem gambler in their household contributed to their addiction or in some way or another. It could have been through the escalation or so forth. Now, I'm not the only one who's done studies that looked at this. Others have well. They found the same thing, that individuals with comorbidity around gambling or gambling disorder and substance use disorder rarely receive comprehensive support they need in substance use disorder treatment. And I want to acknowledge those folks who do substance disorder treatment. You guys are great. You do what you do very well in terms of addressing the substance use, right? But sometimes we become too focused in our approach. And so what I'm advocating for is to expand what we're looking at that individual in a more holistic way, and don't count on that those individuals to self-identify whether or not they have a gambling problem, or as far as that goes, other issues as well. So there's some data out there that looks at, if somebody has a gambling disorder, is it going to impact their substance use disorder treatment? And there's not a ton of evidence out there, but it does, what we do have suggests that, yeah, we know from this one study looking at methadone maintenance therapy that those individuals who had a gambling disorder and also an opioid addiction have much poorer outcomes. Okay, when they're tested, they're more likely to be positive for cocaine use, more likely to be come out positive for opioid use, and they're more likely to drop out of treatment. And when we talk about methadone maintenance therapy, a lot of what we're trying to do is keep that person in treatment, right? We want to keep that person engaged. And so this is something that gets in the way of outcomes in this study, and it's suggestive that this is probably true in other settings as well. So what happens when, the other thing I hear sometimes is, if somebody is dealing with an addiction and we're addressing the addiction and they have other addictions, it's going to get better, right? Because we're talking about kind of a way of being in this world and coping with things and dealing with issues. And so what this study found is those individuals who came into substance use disorder treatment that also had a gambling problem, sure enough, their gambling severity scores went down. So it is true that in this study anyway, and kind of makes sense that if you're kind of dealing with an addiction, treating an addiction, and somebody has a concurrent gambling disorder, a behavioral addiction, and this is probably true with other behavioral addictions, that things are going to get better, right? Because it's about making lifestyle changes. It's really about rearranging your life in a way that works better. However, what else did this study find? Those individuals that did not have a concurrent gambling problem, later on at follow-up, their gambling severity score increased. Why did that happen? So these are folks that did not have a gambling problem. They went through substance use disorder treatment. At follow-up, their gambling severity score increases. Addiction switching, I think I heard. Yeah, I mean, somebody who, we kind of established this, right? Somebody who has a history of addiction is at much greater risk for developing another addiction, which includes a behavioral addiction. So if we don't talk about this when they come into our substance use disorder treatment centers, we are kind of doing a disservice. We're kind of missing something. We're not helping we're missing an important aspect potentially of their longer term recovery. All right, so how do we address this? We have a plan. We didn't go into Nevada and survey all the substance use disorder treatment clinics to say, hey, what are you doing to address problem gambling? But we do know that there's this WITS system that the SAPTA Certified agencies, they fill out data, and there's actually problem gambling screens in there. So they're being asked the questions. Now, what happens if somebody gives a positive response? We don't know. We frankly don't know. Nobody's really tracking what's happening if it's being followed up on. We hope to see that's the case, but there's indications that that's probably not happening. We had a conversation not too long ago with several of the executive directors of substance use disorder treatment programs in Nevada that are SAPTA certified, and we're kind of talking about this program. And one person there said, we have 130 people currently enrolled, and we only have 3 people who have gambling issues. So what that tells me is, and I suspect more than 3 on those 2 questions said yes, or like we were talking about earlier, they don't want to admit it or they deny it. Even if they're asked directly, they kind of know when they're in substance use disorder treatment, like we mentioned earlier, many of them are required to be there. So if they're required to be there, they often don't start out wanting to be there. It's just something they have to do. It's this hurdle they have to get past. Are they looking for any other mandates or conditions placed on them? Do they want any further restrictions on their freedom? Probably not. If they say, yes, I have, yes, I gamble and I try to cut down, I mean, these questions are pretty like transparent, right? So if somebody is savvy at all, they are not going to endorse, even if they have a problem. The motivation may be to not reveal that they have a gambling issue on this really simple screener. Now, later on, when they're in addiction treatment and they're getting it, right? That education, that treatment, the counseling we're doing with them is sinking in, and they're starting to understand how addictions negatively impact their lives. I mean, they're understanding that they need to take action in order to make the changes they want, in order to have the life they want. Then they might say, you know what, I need to get real. Gambling is also an issue for me. So the time to be asking these questions, it's not on the front end. That's not when to be asking these questions. It's to be asking them throughout their treatment process, because we're not sure when they're going to be at a place when they can more freely kind of talk about this and feel it's safe to do so. So we have this project, and this is our project team. I just want to give acknowledgments to these folks. So it's, Kim and I from, and there's a broader group as well, but we're kind of the leads with the state kind of doing this. And Kim and I work very kind of closely together, so I consider, like, you know, we're partners in, it's not crime, partners in doing good things around problem gambling treatment in Nevada. CASAT is working very closely. They're the ones who kind of, you know, I'm not even sure what CASAT, I forget what it stands for. Okay, did you guys get that? Center for Applied Substance Abuse Technology. I got that right. So they're the folks who go out and do the certification accreditation reviews with the SAPTA certified agencies. And so we're working with that team to kind of put together a protocol for this initiative with UNLV, because we want this to be to have a really strong evaluation component, so we could figure out how to make it better, if it's working, if it's something that we can expand. And then also, of course, with SAPTA certified agencies, because they're the ones who are initially where we want to work with to see if we implement this project, if it's going to have an impact. All right, so again, the recap on this is there's a lot of folks who are in substance use disorder treatment that have gambling problems, right? We know from what some of the research suggests is that those individuals with problems with a gambling disorder problem have poor treatment outcomes than if they didn't have that additional issue that they're presenting with. We also know that individuals who have an addiction or have had an addiction are at higher risk. So there's a prevention aspect to this. We want those agencies that are problem gambling capable, that are really doing a great job of talking about and addressing problem gambling, to educate everybody who goes through their program. And by the way, we have examples of this. Bristol Cone, I think, does this. It's just everybody gets gambling groups who goes through that program. But they're also one of our state-funded. So you guys better be doing it right if you're a state-funded problem gambling service provider. New Frontier, same thing. Everybody who goes through those programs gets tons of gambling education. So those people, and I'm sure there's other agencies out there. I don't want to say that other people aren't doing it. But those clients that go through those agencies that are talking about gambling as a potential pothole in the road to recovery, those folks are going to be more likely to, we hope, have a better outcomes in the long term. So, so there's that kind of prevention element as well. So, our goal is really about the client. We want to improve client outcomes. We think by substance use disorder treatment agencies addressing gambling in a very kind of systemic and purposeful way, that's going to happen. There's going to be better outcomes. Not just better outcomes for people with gambling disorders, but better outcomes for addiction treatment. And we do this, again, through making sure that it's part of the education that happens with folks. And there's a couple of different mechanisms or tactics that we're taking. Okay, one is, and this has been accomplished so far, there is now a problem gambling endorsement that a SAPTA certified agency can achieve. Now, a while back, and some of you might have been part of this initiative, there was the ability to receive a dual diagnosis, I think it was, right? A dual diagnosis certificate, what's it, is that right for those of, co-occurring disorder diagnosis. And so what CASAT has done is they've taken that experience that Nevada has had with their SAPTA certified agencies and said, you know, this works. We can put together a implementation manual, a tool guide that really describes in great detail what it takes to be considered it used to be a co-occurring disorder capable treatment agency. We can do that for gambling. So that is the approach. So now there's this new endorsement that SAPTA certified agencies can achieve. Nobody has it yet. We're looking for the first group to achieve that. Now the other thing we're doing is we want to support these agencies. So those SAPTA certified agencies that are going to involve themselves in this new initiative, in this pilot project, we want them to be successful, and we understand for them to be successful, we need to support them. So we're looking at doing that in various ways. One thing that's pretty cool is we're trying to create collaborations between current problem gambling specialty clinics, right, those 4 that we have, and these agencies that are out there willing to engage in this project, so that you can have a local problem gambling treatment expert work within your agencies, and then Kim has set up a way to reimburse those folks for providing that kind of peer-to-peer guidance, right? So you're working with another addictions professional. They know a lot about treating an individual with gambling disorder, and those folks are also mostly, if not all of them, have SUD treatment experience as well. So that's one thing we're doing. We're also doing a lot of training. CASAT has set up there already a whole bunch of different educational programs that people can access right now who want to kind of do this. And then we have, again, this whole toolkit that will help the agencies understand exactly what they need to do in order to become a problem gambling capable. Now, what does that look like? So this is not just going in and coming to a conference like this and saying, okay, now I am ready to have, I am now a problem gambling capable SUD treatment center. Rather, we're looking at a very kind of comprehensive model here. So what this is saying is if you want to achieve this certification, you need to meet the benchmarks for all these different things. So it kind of starts at the organizational level. When somebody goes to your website, is gambling anywhere mentioned there? Is it even part of like your mission? Like, are you so focused in terms of what you say you do that gambling is just, that it's all about substance use disorder treatment and other behavioral addictions just are kind of excluded? So we want to see that there's a presence on the website. We would like to see that there's somewhere on the org chart, there's maybe a problem gambling integration coordinator that's assigned. So it kind of starts at this kind of organizational commitment. The staffing, we want people to get certified as problem gambling counselors. We're also doing some other things to make that easier that we're actively working on, because it's a big hurdle to actually become a certified problem gambling counselor in this state. But we're working on ways that a new level of certification that will make it the ability for folks to kind of get certified in different ways. And community engagement. When you go out and you promote your agency to the public, are you talking about gambling? Are you kind of recognizing gambling? The program structure, the clinical process, the continuity of care. So there's all these different areas that we look at that are being assessed. So when somebody with an agency that is participating in this program, all SAPTA certified agencies get a review, an accreditation review, I think every 2 years. And so now, if they are a part of this program and they want to be achieve this certification as this problem gambling certification, then that certification review includes looking at these different components. If they meet those components, then they get that certification. And every 2 years, this happens. They go back and they do this. We're also looking at some really cool things on the evaluation aspect as well. I'm tracking the clients to see if, in fact, this really is making a difference for folks. And when they do identify that they have a gambling problem, which maybe they're more likely to do if it's an independent evaluator they're reporting to, that we tell it. We're looking at collecting a lot of anonymous information, so to get around that barrier that we were talking about earlier. So and then we're able to kind of come back to them. We could still identify who they were without knowing their name, kind of thing, and going back later and find out, hey, was this addressed on your treatment plan? Are your urges, do you have any urges going up, and so forth? And then we track them out in time. So the implementation steps is we develop this strategy. We have these toolkit. We have these program components. Okay, so we have this toolkit. The toolkit's pretty much done. By the way, the main part of it's done. We have a training program, so we go in and we work with participating agencies. We have this new endorsement. The technical assistance, again, one way that technical assistance happened is with this peer-to-peer relationship with these problem gambling specialists. And by the way, we think that that is going to increase treatment both within being addressed within the SAPTA Certified Substance Use Disorder Agency and within the specialty clinics. Because some of those folks, what's most appropriate is when they get discharged, they go over to a specialty clinic, right? Or they do that in conjunction, and it's okay to do this, to be working over here with some problem gambling specialists, and then to be working over here on some continued recovery work around your SUD addiction. And then the program evolution, we're again looking at this new level of certification, we're exploring that, and then system integration. So we're starting this by doing a pilot program approach. So we want to get 5 agencies, and by the way, if you're in this room and you're a SAPTA certified agency and you're interested in signing up for this, sign up. You also get money, by the way. So you also get money that would, if you sent somebody to this conference, for example, you could use the money to pay for their time to be here, as well as registration, which is super minimal at this conference. But if they want to register for other events as well, so there's some financial compensation as well, because we do recognize that there's a level of effort that goes into meeting this, the criteria to be have this endorsement as a problem gambling capable agency. And then with that, we hope to expand it. So down the road, this might be something that is that's commonplace. It might be something, depending on what the data shows, if we're getting really nice results, this might be something that folks who are doing SAPTA certified treatment, SUD treatment, just might have to engage in, depending on how things go. We don't know. So that's kind of where we're at right now. We're seeking out some partners. Again, come talk to Kim if you want to be one of these partners. And in summary, this is me. This one I had a lot of hair. And I used to wear gold chains. And my dad, he's so everybody, when I talk about my dad's history and my personal experience with gambling problems, they always say, and I forget to say what happened to my father. It's they always come up after, oh, well, what happened, right? So with him, what happened is, it's interesting. I frequently kind of talk about pain and how pain is so useful in recovery. And usually what I'm talking about is emotional pain, and we need people to be in contact with that pain in order to kind of motivate them to take that step to get into action and seek services. And even when they're in services, we don't want all their pain to go away. We don't want to rescue them and shield them from that pain right away, because then they lose their motivation. They drop out. Okay, they're more likely to drop out. We want to use that. And pain is our ally, I feel. Now with my father, his pain was actually physical pain. Back then, when you had to, his form of gambling, and this is the only gambling he really did, was that racetrack. You had to walk. This was before you could do it on your phone, right? So this is way before internet or anything like that. And there was a lot of walking. And I don't know if those of you who know much about the old betting on races in the past at the track, but there's a lot of walking involved. And so his hip pain got worse and worse, and so finally he's like, it's too much pain to go to the track. And that, and I think the other huge piece was my mother, because she just would not let him get away with it much more. He says it was the pain, not my mother, but I actually think my mother had a bigger role in it to do with it. And he passed away at the age of 88. He had not gambled for a good 20 years before his passing away. And he never acknowledged he had a gambling problem. Up until he was 88, he never had a gambling problem. So we know gambling disorder occurs, that's a recap, in about 3 to 4% of Nevada's general population. Manifesting a substance use disorder increases the odds of a gambling problem by 3 to 5 times. Even a history of a gambling disorder can potentially impact substance use treatment and recovery, and is commonly not addressed. Behavioral health outcomes improve with greater awareness of gambling behaviors. And this new gambling integration pilot project is an important step to better address problem gambling in Nevada. And Kim kind of mentioned to you already the programs we have, but there's some great stuff on the Nevada Council on Problem Gambling's website. I think this came from your website, is that right? So this is this great thing on reasons why you should screen, why you should have a conversation. And a lot of what we're talking about is to have those conversations. And you guys are all ambassadors, so I want you to, go out there and spread the word. You need to, if you're working with anybody that's with an addiction issue, or really mental health issue, even hopefully into our physical health clinics, gambling should be talked about. And these are some reasons why. Again, these are our specialty clinics. And there's times for questions. All right, thank you, everybody.